Great. Thank you again for your attention, and I'm really excited to get started on our conference. Our first speaker is Dr. Christina Ha from the Inflammatory Bowel Disease Center at Cedars-Sinai Medical Center. She's an outstanding physician, researcher, and friend, so I'd like to welcome Dr. Ha, and this is our first in-person speaker, and Dr. Ha was commenting, and we are actually here as human beings. Thank you, Tina.
Thank you so much for having me. It's very exciting, and I get to learn how to use a podium and slide decks and wear shoes. So I'm going to be talking, which may take a few sessions before we get comfortable. These are my disclosures, and these are the objectives. We're going to highlight some major studies that were presented at DDW. Even though it was virtual this year, there were still some very important studies that can impact clinical practice. We're going to talk about the Seaview study, which is a head-to-head comparison of ustekinumab and adalimumab. We're going to talk about the Stardust study, which is a treat to target using ustekinumab. Osanamod was recently FDA approved for moderate to severe ulcerative colitis, so we're going to discuss the latest updates and how to incorporate them into your practice, and to review the latest updates on tofacitinib. So let's get started with Seaview, which was the first head-to-head study of ustekinumab versus adalimumab for moderate to severe Crohn's disease. We do know from Varsity, which was a head-to-head study of adalimumab versus vedolizumab, that gave us some insights to the positioning of those agents for our patients who are bio-naive. So these are patients who are adults who had moderate to severe Crohn's disease based on the Crohn's Disease Activity Index, score between 220 and 450. They had to have failed steroids or immunomodulators in the past, but all patients were biologic naive. So they had never been on any mechanism of action that's in a biologic preparation. And they had to have at least one ulcer, which was defined as being greater than 5 millimeters somewhere throughout their small bowel or colon. And that translates to a simple endoscopic score for Crohn's disease greater than or equal to 3. At randomization, they based it on steroid exposure, their CDAI score being greater than 300 or less, and how the ulcer is greater than 5 millimeters at baseline. Their treatment was a weight-based dose, which was standard for clinical trials, of 6 mg per kg for IV induction, plus 90 milligrams sub-Q every 8 weeks for ustekinumab, and then they were given placebo doses of adalimumab at the schedule of adalimumab. For the adalimumab-treated patients, they were given a placebo infusion of what would have been ustekinumab had they been receiving it, and a placebo injection every 8 weeks. Now, this was a treat-through study design, which meant that all patients continued on to maintenance therapy, unlike regular clinical trials where clinical responders tended to be re-randomized to maintenance. Also, there was a mandatory steroid taper after 8 or 16 weeks, so all of these patients were forced to come off steroids. Importantly, this was a study designed based on monotherapy of ustekinumab and monotherapy of adalimumab. And the primary endpoint was looking at clinical remission at week 52. And as you can see here in this head-to-head study, ustekinumab is the blue bars, and adalimumab is the reddish or orange. And at week 52, the percentage of patients in clinical remission for both groups of these biologic-naive, forced steroid tapering patients was actually quite good, 65% for ustekinumab and 61% for adalimumab, which indicates that both medications are very good for our patients as a first-line treatment. The major secondary endpoint was steroid-free clinical remission at week 52. And what's important to note is that you see similar percentages of patients who had steroid-free clinical remission as clinical remission. So again, not only do most of these patients achieve clinical remission at week 52, many of them were steroid-free, which is the desired clinical outcome for many of our patients, suggesting that both medications are very good. In terms of the major secondary endpoints, clinical response between the two groups, as well as endoscopic response, although numerically higher for ustekinumab, were statistically no different, again suggesting both agents are similarly effective. We are always wondering about rapidity of onset of action. And as you can see at this curve, this looks at clinical remission, defined as Crohn's Disease Activity Index score, less than 150. The curves were pretty much superimposed, which tells us that the majority of the patients who were receiving adalimumab or ustekinumab were likely to achieve clinical remission by week 16 to 24, when the curve started to flatten out. But 50% of patients really started to achieve clinical remission by week 8, again on monotherapy, forced steroid taper at week 8 and 16, and no allowances for dose escalation. In terms of the safety profile, very similar between both groups. There were more injection site reactions amongst the adalimumab-treated patients and potentially more patients who discontinued study drug with adalimumab, but overall, the safety profiles from this study were very similar. So what's the takeaway? Both agents are effective and safe for biologic-naive Crohn's disease patients with moderate to severe disease. And what's really reassuring is to see these relatively high steroid-free and clinical remission rates at week 52 from a treat-through design. Both agents appear to be effective by around week 16, and no new safety signals were identified. So our take-home message is both are very good options, and we should present them as such to our patients who are bio-naive. And it's an important study to discuss with our patients as we're talking about decision-making, as this is our first head-to-head trial. But factors to consider are insurance coverage and access, adherence. Some people may not be as adherent to an every 2-week dosing versus every 8-week. Some people may be more adherent, as well as patient preferences. So now let's move on to talk about Stardust. So this is a study that was somewhat loosely based on the CALM trial. And as you may or may not recall, the CALM trial was a randomized controlled trial that looked at 2 different monitoring strategies and optimization strategies for patients with moderate to severe Crohn's disease, where they were randomized either to a biomarker steroid-based optimization arm, where they had increasing doses of adalimumab that an immunomodulator added, versus standard of care treatment for dose optimization. For these patients, they were actually randomized to a treat-to-target versus standard of care for ustekinumab. But the primary endpoint was different. For CALM, it was clinical remission. Here, it was an endoscopic improvement. So these patients had moderate to severe Crohn's disease, and they failed conventional therapy or 1 biologic. And basically, their primary endpoint was a 50% improvement in their simple endoscopic score for Crohn's disease at week 48. The trial design is a little bit complex, but basically all patients were given the standard weight-based induction dose of ustekinumab, and they received the standard maintenance doses per the FDA prescribing label of ustekinumab at week 8 and week 16. Responders at week 16 were then randomized to either the treat-to-target group or the standard of care group. Patients who were in the treat-to-target group then underwent a colonoscopy. If their colonoscopy showed a 25% improvement from their baseline scope, then they were actually dosed at maintenance of every 12 weeks. And that's important to keep in mind because we don't dose based on every 12 weeks. We dose at every 8 weeks for maintenance. Patients who didn't have that improvement were then escalated to every 8 weeks, compared to the standard of care arm where they were just given every 12 weeks or every 8 weeks based on the physician's discretion on their symptoms and their response. And additional dose adjustments subsequently were based on biomarker-related parameters. So this is a little bit tricky to read because it doesn't project as well, but this goes to show that both of the treatment groups are relatively similar in terms of age, duration of disease, body mass index, disease location, and prior medications. But I want to highlight a few things. Most of these patients are probably more within the moderate range of their Crohn's disease activity index because severity is really defined as greater than 300. Their simple endoscopic scores were around 13. They did have elevated C-reactive proteins, pretty elevated fecal calprotectins, although the standard deviation was quite wide. And about 40% of them were biologic naive. The rest were previously exposed to biologics. So this is important as we're looking at these week 16 response rates. So remember that only the patients who had a response at week 16 were randomized to either the treat-to-target or the standard of care group. And what's important to note is that 60% of the patients in both groups actually had either enough endoscopic improvement or were clinically doing well to either remain on the every 12-week dosing, which is not a standard dosing we use in practice, and about 50% of the standard of care group remained on the every 12-week dosing. But based on the endoscopy, 40% were escalated to every 8 weeks, which showed that they did not have greater than 25% improvement from their baseline, and about 47% of patients were escalated to every 8 weeks just based on their clinical symptoms alone. So by the end of the trial at week 48, you can see that the majority of the patients who were on the treat-to-target group had either some form of dose optimization, either to Q4 or Q8 weeks, as only 36% remained on Q12 weeks, and they had about a 20% discontinuation rate. Whereas in the standard of care group, the majority of the patients were on standard every 8-week dosing, about 35% were on Q12 weeks, and about a 13% discontinuation arm. And what this tells you is these low discontinuation rates at week 48 indicate the safety or the tolerability of this medication. So let's look at the primary endpoint, which is endoscopic response at week 48, a 50% improvement from baseline. And as you can see, comparing treat to target, the dark blue, compared to the medium shade blue, which is standard of care, even though numerically they were higher, only when they did last observation carried forward or non-responder imputation, including discontinuations due to inefficacy, did they start to see the differences in endoscopic improvement. So the difference with non-responder imputation is basically if they were lost to follow-up, if they discontinued, or if they didn't respond, they were all considered non-responders for all the time points. Last observation carried forward means if they dropped out of the study, they discontinued due to intolerability, their last observation prior to discontinuation was the metric that was used in the statistics. When you look at clinical outcomes between the treat to target and the standard of care groups, they are pretty much the same across the board. The Crohn's disease activity responses, the clinical responses, and clinical remission. But something to keep in mind, we all know that clinical factors don't necessarily mirror endoscopic response. So while it's reassuring to see that these curves are pretty much similar between the two groups, it's hard to know whether or not this was actually a meaningful difference or lack thereof. Biomarker outcomes between the two groups is more informative because these are more objective variables. And as you can see, normalization of fecal calprotectin, this first set of bars right here, normalization of C-reactor protein, or both normalization of C-reactor protein and fecal calprotectin were similar between both groups, whether you do the non-responder imputation or the last observation carried forward. So this is a lot of numbers. So what is the take-home message here? Well, basically, they only saw a numerically higher percentage of endoscopic response at week 48. There were higher rates of clinical remission, biomarker response, and endoscopic improvement at week 48. But keeping in mind that 60% of these patients are biologic exposed prior to enrollment, what we saw was this, is that ustekinumab for these patients actually worked quite well. For some patients, even a Q12-week dosing may be appropriate, but it would have been interesting to see if they had randomized to every 8-week dosing and allowed for optimization to every 4 weeks, because even with this dosing strategy, only about a third of the patients achieved endoscopic response with a 50% improvement by week 48. So this doesn't mean that treat to target doesn't work. There may have been some flaws in the study design, but what this tells us is that this is a safe medication, it's an effective medication, the durability or the persistence of therapy was good, and for some patients, actually Q8-week dosing is very likely to be all that they need. All right, so now let's talk about Osanamod. So Osanamod is the newest mechanism of action on the block, FDA approved towards the end of May, and it's important for us to understand the mechanism because we're gonna have to explain it to our patients. So what this is a sphingosine-1 phosphate receptor modulator. So basically, what are S1Ps? Well, S1Ps are found in lymphoid tissue. And there are 5 different forms of S1Ps, and Osanamod, the newest one on the market, works on S1P1, whoops, let me go back. That's all right, S1P1 and S1P5. So we have to understand how do we explain this mechanism of action to our patients? Well, we're all familiar with the concept of trafficking. And so when you think about vedolizumab is an anti-trafficking agent, if you will. So it prevents the lymphocytes that are primed to go into the GI tract from leaving the blood vessels and entering the GI tract. Basically, and so I always tell people it's like cars on the highway and you're blocking the exit. Well, basically, the way that these S1Ps work is that you're actually blocking the entrance to the highway. So you're blocking the lymphocyte egress from the lymphoid tissue, like the lymph nodes, from entering the blood vessels. That's why lymphopenia is actually such a prominent finding in some of the lab work, but doesn't translate to increased infections. So basically you're blocking the lymphoid egress, lymphocyte egress at the lymph node level before it can enter the blood vessels and then reach sites of inflammation, because this is overexpressed in tissues where there's active inflammation. So that's probably the simplest way to explain it to your patients. So how did this get FDA approved? Let's look at the True North study data. So this is the phase 3 randomized control trial looking at Osanamod for the treatment of moderate to severe ulcerative colitis. Their primary endpoint was week 10 clinical remission, which was defined as a rectal bleeding score of 0, a stool frequency score of 0 or 1, and a Mayo endoscopic score of 0 and 1. And as you can see, statistically significant, more patients, 18% versus 6%, achieved that endpoint at week 10. Other secondary endpoints, response, endoscopic improvement, and mucosal healing were also significant at week 10. And then the maintenance study data. So Only people who had response at week 10 were randomized and enrolled into the maintenance study. So keeping that in mind in your clinical practices, if a patient doesn't have a response to this agent at week 10, knowing that it has a longer washout period, you may need to start considering a different mechanism of action. So looking at all the endpoints, clinical remission and the others, statistically significantly more patients achieved the clinical remission endpoint at week 52, 37% versus 18.5%, and it met all of the secondary endpoints, which is pretty impressive. So one of the things that our patients always ask is how quickly is this medication going to work? And that impacts positioning, because if it's slower onset, we may not necessarily want to consider it for our patients who are having a severe flare. So when we look at rapidity of onset, some of the key metrics that we look at are stool frequency scores, and this is just the first category in the Mayo score, rectal bleeding score, fecal calprotectin, and C-reactive protein. In the True North trials, the stool frequency and all those scores were relatively similar between placebo and Osanamod. Obviously, it was a randomized controlled trial. And basically what they found was that a significantly greater proportion of patients on Osanamod achieved meaningful scores, a rectal bleeding score of 0, 52% by week 10. So 52% of patients who received Osanamod had a cessation of rectal bleeding by week 10. 42% had a stool frequency score of 0.1, so either at baseline or 1 or 2 more bowel movements greater than their baseline. And about 35% had that combined endpoint of a rectal bleeding score greater than 0 and a stool frequency score greater than 1, less than or equal to 1. At week 10, you can see marked decreases in fecal calprotectin, week 5 C-reactive protein, and week 10 C-reactive protein. So it does work relatively quickly. We all like to see these flow charts because of the tofacitinib studies, and you can see that for patients who have a rectal bleeding score improvements, it really starts to occur around week 2, and then it starts to plateau around week 5. So as we're counseling our patients, we can say, okay, you might start to see some improvement in rectal bleeding as soon as week 2, but we really need to give it up to at least week 5 through 10. For stool frequency, you start to see the improvements around week 5, and then it starts to plateau closer to week 8 to 10. So let's talk about adverse effects, because that's what's some of the concern about this medication, because the package insert, there's a ramp up, so you have to increase the dose gradually every few days until you reach the standard dose, which is 0.92 milligrams, and then you are on 0.92 milligrams for the induction of 10 weeks. So the main adverse effects that were noted during induction were nasopharyngitis, nausea, pyrexia, elevations in ALT, and arthralgia. So these are some of the things that you're going to be asking your patients about during the ramp up and during the induction. Also means that you have to monitor some of these labs. Additionally, some of the most common treatment-associated adverse effects, understanding the mechanism of lymphocyte egress blockage, lymphopenia, so you do need to monitor their lymphocytes. However, while they do drop down initially pretty low, they do tend to stabilize and drop. They don't drop too much lower than that after induction. So basically this means CBC and CMP monitoring is going to be essential for these patients to monitor their lymphocytes as well as their liver enzymes. What about the cardiac abnormalities? Because in the package insert, there are a list of patients who Osanamod may not be the right treatment. And so patients who have a history of conduction abnormalities, unless they have a pacemaker, may not be the right patient. However, in the clinical trials, they predominantly saw bradycardia. It was mostly during the ramp-up period and during induction, but it was not associated with anything more than first-degree block. So anything more than second-degree type 2 or higher was not seen. Macular edema, so for some patients who may be predisposed to macular edema, it is required to have an ophtho exam prior to starting Osanamod to make sure there are no features suggestive or potentially concerning for later development of macular edema, but relatively low rates, only 0.2% during induction and 0.4% overall. So when we talk about infections, because a lot of our patients are risk averse, if you're blocking the lymphocyte egress and you have this lymphopenia, am I going to be sick all the time with all these viral infections? And as we had mentioned earlier, nasopharyngitis, most common during the induction period, less so when you combined all the UC studies, including phase 2, 3, and open label extension. upper respiratory tract infections, opportunistic infections, zoster, and serious infections, mostly during induction. So yes, you do have to monitor for viral infections. It is recommended that you get the zoster vaccine prior to starting Osanamod if you can, but basically viral infections, much like many of our medications for ulcerative colitis and Crohn's disease, because they work on lymphocytes, specifically T cells, are going to be an issue. However, most of the adverse effects were reported during the first 3 months of the trial. So if patients can tolerate and they can get through the first 10 weeks of Osanamod without any major adverse effects, then the likelihood of more adverse effects with longer exposure to the medication appears to be lower. So basically, the conclusions were they saw PRO improvements in terms of stool frequency and rectal bleeding as early as week 2 for rectal bleeding and week 5 for stool frequency. Biomarker improvements were noted by week 10 amongst responders, and the most adverse events were similar between Osanamod and placebo-treated patients, with the exception of during induction. So monitor more closely during induction. So the take-home message is that it is an important MOA for our moderate to severe ulcerative colitis patients, and this is going to require monitoring. So as you're prescribing this, you have to have your monitoring checklists, and you have to play close follow-up with these patients. But again, with a treat-to-target strategy for patients who have moderate to severe disease, you're going to be monitoring them closely anyway. The pre-treatment workup is essential, and a washout period is needed before and afterwards because it does hang around the system a little bit longer, and it's meant to be monotherapy, not in combination with thiopurines, methotrexates, biologics, or other small molecules, but only monotherapy. And so you have to consider insurance coverage, access, adherence, not only to the medication, but also to the follow-up and the monitoring, preference for oral and injectable infusions, and medication interactions. So the same type of strategies that you would be using, for example, for our thiopurine-treated patients, you're going to have that sort of model for Osanamod-treated patients. Now let's talk about the post-marketing safety of tofacitinib. It's been around for a few years now, and basically this study looked at over 4,000 moderate to severe ulcerative colitis patients who were prescribed tofacitinib in the first 27 months after its regulatory approval. And basically, these are all the different adverse effects that were voluntarily reported into from this post-marketing surveillance data. And focusing on the key ones that usually strike our interest, infections, vascular disorders, cardiac disorders, and neoplasms, what we see is that most of the adverse effects were non-serious, which is the blue, versus serious, which is the purple. And you can see the majority are non-serious in this voluntarily reported data. So if we look at the serious adverse events that were reported, there was about a rate of about 3.3 for the infections per 100 patient years. For vascular disorders, about 1.3 per 100 patient years. Cardiac disorders, 0.5 per 100 patient years. And neoplasms, 0.5 per 100 patient years. But then let's look in more detail as to what these were. So in terms of the neoplasms, breast cancer, colon cancer, lymphoma, malignant melanoma, prostate cancer, and non-melanoma skin cancer. Similar observations with rheumatoid arthritis. But this is true for all of our IBD patients. Sometimes we neglect their routine screenings and preventive care. All of these have screening strategies, mammograms, colonoscopies, or FIT testing. Lymphoma is harder to screen for, but skin cancer, prostate cancer checks are very important for all of our patients, but potentially more so for our tofacitinib-treated patients. The MIs, 8 MIs for angina, for pericarditis, similar to RA, and the venous thromboembolic risk, you have to consider that also with respect to their functional status, other medications, disease severity, steroid use, hospitalizations, recent surgeries, particularly orthopedic surgeries. So all of those in context, really no new safety signals were seen in post-marketing surveillance among UC patients, similar rates of cancer. The most common adverse effects were GI effects, hemorrhage, rectal bleeding, or UC flare. That's not necessarily an adverse effect of the medication. That's more lack of effectiveness. And there's a potential for underreporting because these are all voluntarily reported. But at the end of the day, we all know that patient selection is really key for tofacitinib. It is a good medication, but much like Osanamod, you have to think about which patient is the right patient for this mechanism. So finally, in the last couple of minutes, we're going to talk about this somewhat controversial but eye-opening study that was presented by Peter Higgins and the group at Michigan. So right now, for our patients who are hospitalized for acute severe ulcerative colitis, we really only have 3 options: infliximab, cyclosporin, or colectomy. So what about our patients who maybe previously were exposed to biologics and they present to the hospital? What are their options? Well, here they treated patients with a combination of IV corticosteroids plus tofacitinib, dosed either at 3 times daily or 2 times daily based on basically their preference. And their outcomes of interest were 30-day and 90-day colectomy and 90-day complication rates. And basically what they saw was the dose that may be appropriate for our hospitalized acute severe UC patients who've had a history of biologic exposure, for example, that 10 milligrams 3 times daily had actually a statistically significantly lower 30-day and 90-day colectomy rate compared to just using IV corticosteroids alone or a 10 milligram BID dose. The 10 milligram BID dose was essentially the same as corticosteroids. And remember, this was in addition to IV corticosteroids. So the 10 milligram TID dose may be something that requires further exploration. In terms of the patients who did end up going for colectomy who were treated with TOFA, there were about 6 of them, but 0% had a post-surgical infection. So for these TOFA-treated patients, basically the washout was 18 hours preoperatively, and then they went on to surgery. So overall, for the conclusions for tofacitinib, 10 milligrams 3 times daily, still very premature. We're not recommending this for clinical practice yet, requires further investigation with IV steroids, may be associated with a lower risk of colectomy for biologic experienced adults, patients. But we have to keep in mind that this is colectomy-free survival was their endpoint. It wasn't clinical remission, it wasn't mucosal healing, it wasn't steroid-free remission, which is our obvious goal endpoints. So we don't know if this is going to reach those endpoints over time. No increased complication or safety signals noted, and many questions remain. What's their maintenance dosing after discharge? How do you taper steroids after discharge? And we want to see what those other objective endpoints are aside from colectomy-free survival. However, it's intriguing because this is potentially a much easier mechanism of action to offer our patients in the hospital setting than something like cyclosporin. So with that, that is the end of my talk, and I will hand it over to my colleague.